There we go. So before I introduce the presentation, just to let you know that if you've got any questions throughout this presentation, please put them in the chat box. You should see some of the conversation in the chat already. If you put any questions just throughout the webinar, and then they'll be addressed at the end by Tom, and we will pose those questions to him then. So just to give you a brief introduction of who the Health Special Interest Group are. They were launched in September of last year and are currently covering 3 work streams. So quality in healthcare, which is the presentation that we'll have today, quality in medical devices, and quality in medical laboratories. They are a new committee and they will be developing more webinars and content over the coming year. If anyone is interested in getting actively involved, then please get in touch with us via sigs@quality.org, and I'll put that in the chat if you would like to find out more about being on the committee and being involved in the special interest group. So today's presentation will see Dr. Tom Rose take us through the current situation of quality management used in the NHS, in particular in UK healthcare. Dr. Tom has been an active CQI member for over 40 years. He thrives on continuous improvement and understanding its ineffectiveness without process management. He was an engineer for most of his working life, but for the last 5 years has been looking at quality in the NHS as a research fellow at the University of Birmingham. He's a member of the Q community, which is part of the Health Foundation. So Tom, I'm going to pass over to you to take us through quality management in the healthcare and where to start. So thank you, Tom.
Thank you, Caroline. Hello, everyone. As Caroline said, I'm a retired electrical engineer and I'm now a research fellow at the University of Birmingham, researching quality management in the NHS, and also doing a bit of lecturing on quality and patient safety to students at the university. As the title suggests, I'm going to talk about quality management in healthcare. The question is, where do you start? It will take more than just a single webinar to answer that question, so we've got more webinars planned on this same subject. This first presentation will present an issue that's prevalent in healthcare, and that's just not in the UK, it's worldwide. Then I'll look at some evidence that supports this issue. Then I'll look at the control measures that are in place to mitigate this issue. That's mainly in the UK, but the same evidence can be found in most healthcare settings across the world. The question is, are these control measures working? Additional evidence will be presented, which hopefully go partway to answering this question. The healthcare sector internationally do have a multitude of improvement initiatives. I'm going to talk about those in place in the NHS, but other countries will have similar initiatives. Next, I'll look at the question, is there any quality management in healthcare? We'll have to have a joint decision on whether that's the case or not. And finally, there'll be a question and answer session. So let's get started. In this first presentation, I'm going to paint a picture in your minds rather than come up with a solution to an issue. The issue is just too big. The picture will, I hope, encourage you to dig a bit deeper into the issue and formulate your own conclusions, and to help me formulate, or the CQI formulate some conclusions, so some solutions. So the content, first of all, as I said, I'm going to present an issue, then look at the evidence that supports this issue, look at the control measures that the NHS have got in place, ask the question, are these control measures working or not? And then what's this telling us? Have a look at some of the improvement initiatives that are being undertaken in the NHS and whether they're working or not. And then have an initial look at what quality management in the NHS might mean. And then we'll go on to a questions and answers session. If you could, as Caroline said, if you could put your questions into the chat, then we can answer them at the end. So first of all, the issue. Right, the issue is there are too many errors and violations in the delivery of healthcare. This results in poor patient safety, poor clinical outcomes, and poor customer service. Now, is this a real issue worldwide? Well, I use Google extensively in my research, and lectures. This gives everyone in the audience the same access to the information presented and an option to undertake further research. I think that's important that people have got that ability. If you put this issue statement word for word into Google search, you'll see that the World Health Organizations have lots to say on the subject. You might find the results pretty disturbing since we're so reliant on healthcare. When I put the words into the Google search, I got 9,500 hits within 0.31 seconds. It just shows how much interest there is across the world in this subject. So let's have a look at the evidence that supports this statement. Fitness to practice, public inquiries, distractions, interruptions and variation, that there are a lot more words or phrases that you can Google that will produce evidence to show that the issue is real. Fitness to practice, this is a website where doctors are assessed as to whether they're fit to practice. That's not only because they've done something wrong. It might be just doctors from abroad who want their qualifications checking. But you can see just from this month, there are a number of cases being heard, and there's this number of cases going on all the time. You can investigate that further. There's a quick paper from the British Medical Journal. Takes a bit of time, and this is looking at the number of cases that have gone on in the past, and they're talking here about 11 doctors having been charged with medical gross negligence and manslaughter in the UK between 2006 and the end of 2013, and of these cases 55% were convicted. And it says that since December 2014, more doctors have been charged with medical manslaughter and are waiting trial, and there's a 55% conviction rate. Again, fitness to practice. This is a report from the Medical Council, and there's an interesting table here that these are the number of doctors that have been had a case put against them for fitness to practice, and you'll see that the numbers are quite high. More evidence, investigations. These are the Care Quality Commission investigations against errors in healthcare. You'll have to have a look at this website yourselves to get a better picture of what's going on. This is the most current investigation, and funnily enough, this investigation, it's from Shrewsbury and Telford, and it's about the maternity scandal, and it's actually on Panorama tonight, where they're going to discuss this. I've heard some clips from the programme, and it is extremely interesting. This issue was raised in 2016, 2017, but the final report is still yet to be published. There was an interim report published in 2020. Funnily enough, one of the issues raised by this report was that the trust was trying to meet a target set by the government or set by somebody that said we need to reduce the number of C-sections, and that's where babies are delivered through the stomach, cesarean operation, and a lot of babies were dying because girls were not allowed to have the baby in the normal through C-section when really they needed it. So I'm going to come on to targets and the impact that they've had a bit later on. The previous report was mid-staffs. Sorry, I've got to reload this through Word, and I've highlighted a section here. The mid-staffs public inquiry was some time ago, but they're saying many areas of healthcare provision are now generally subject to standardisation. I'm not sure that I've seen evidence of that, But they're saying at the time there wasn't any standardization, and some professionals object to what they see as the restriction of their professional freedom when they're subject to standard working practices. But they're saying because there wasn't enough standard working practice, this is where errors are come in, and it also increases the variation in output through the NHS. So that was a Williams report. That was a report after the mid-staffs investigation. Another piece of evidence is the number of distractions and interruptions that happen during the day-to-day work of people working in the NHS. And this is a story about the number of errors that have been caused by nurses that are delivering the medicine getting distracted by people asking them questions. The reason they're asking questions is because they're not actually certain of what they're doing or where information is that they need. There's no standardization of working practices. So the solution was to give all the nurses that were delivering drugs red bodices, so that that meant that they weren't allowed to be interrupted through for any reason whatsoever. There's another paper here on the effect of all the distractions that go ahead in medical practice, and how many accidents have been caused by people being interrupted during their procedure that they're doing at the moment. And it says in there that some doctors, actually in operating theatres, are distracted several times per hour. Again, you'll need to look at some of these websites yourselves to get a better view of the implications of what's going on. Variation is the variation in the output, really, or the quality of care that's given across the NHS and the effect that that has. And there's a lot of work goes on within the NHS to try and compare hospitals so that to try and reduce the variation. And I'll come into this a little bit further. But the reason there is so much variation is because there's no standardized working practices. Is it possible to standardize work in the NHS? Every patient's different and every illness presents slightly differently in each patient. Well, it depends on how you address the activity of standardization. I'm sure that it could be done. Anyway, one solution for the NHS is to try and manage the variation in some way. And there's another paper. If you Google any of these key words, you'll find reams of evidence on the internet suggesting what the problem is. So that's the evidence that the issue that I raised is actually a real issue. So we'll look at some control measures now that the NHS have put in place. They've got policy, they've got loads of policy. They've got what are called standard operating procedures. They've got protocols. There's NICE. There's legislation. There's training, and there's quite a lot of other control measures. And there's too many really to cover here. But I'll have a look at the complete list of control measures a bit later on. The problem with most of these control measures is that they're trying to control the output levels, the output quality, rather than how you get to the output. Here's a note that's been produced talking about protocol standards and policy and guidelines. And unfortunately, the NHS don't really know, and it might be the government, don't really know the difference between policy and process and procedure and standard and protocol and guideline. So a lot of their documents have a mixture of all of these topics in the one document. So it's very difficult to implement across the board, where a policy might be published in one paper but relevant to another section of the NHS. So this is just something that's been published to try and sort that problem out, but I don't think it actually works. NICE, talking about standardized procedures, NICE have got a procedure for just about every single complaint that you can think of, and they use quite a good flow charting technique, and these techniques drill down into different elements of the problem, and this covers just about every single illness that is under the sun, as I said. But there's no compulsion for these NICE guidance or standards to be followed. And I'll come on to some more information about that a bit later on. I'll just go back to talking about the benefits of the NICE guidance, how NICE guidance can be really useful. But as I said, there's no requirement for those standards to be followed. Legislation, there's loads of it. You can find legislation that covers just about everything that goes on in the NHS, but it is just legislation. Interpreting that legislation into actual working practices requires more than what's going on at the moment. But you can be sure that this is the sort of documentation that is used in the public inquiries. Training, this is post-basic training. Post-basic training. The Academy of Medical Royal Colleges have produced this National Patient Safety Syllabus, which I think is really good, but there's no compulsion for people to undertake this training. And just whilst we're on patient safety is treated differently to quality in the NHS, when really they're the same thing. It's a fall down of quality that presents patient safety issues. Another aspect of training, a bit slow sometimes, I'm afraid. The Royal Marsden Hospital have produced a gold standard for nursing practices, and it's a book. It's been published it's in the 10th edition, you can see there, but it's also online, and this covers just about every single nursing practice that you can think of, from taking blood to changing a catheter. So there's all sorts of, or just changing a dressing, or washing a patient, or moving a patient from one bed to another. So there's lots of information there that that really does standardize practices, but it doesn't actually, it's not actually compulsory. So not everybody will use those Royal Marsden standards. This is one that I like. It's a national safety standard for invasive procedures. And this is where the NHS have tried to produce a standard that prevents problems in surgery. But it doesn't only cover operating theatres, it covers having a tooth extracted as well. So this is a national standard, and it is very good. It is a good standard. I quite liked it when it came out. This standard has got to be enforced within trusts by them writing their own local standard, so that they don't work to this standard. They've got to produce their own local standard from this standard. And this is quite a good standard. You can see it covers 49 pages, and we'll have a look in a minute at what the NHS what the trusts have done to implement that standard. And that is, they've produced a checklist. This is a World Health Organization checklist for invasive surgery, and it really is what that standard that I just covered stemmed from. And I'm sort of asking myself, does a checklist cover, or is a checklist equivalent to a written standard? I'm not sure that it is. And you can see that there are a lot of different, well, it doesn't show you there, but there are a lot of checklists that have been produced to implement standards. And checklist versus procedure. This is a procedure to fill in a checklist, and it's 25 pages. And it's just a procedure telling you how to fill in a checklist. And it's just a little bit confusing to me as to what comes first, the checklist or the procedure. I'm a bit confused. But anyway, checklists are very popular in the NHS. The World Health Organization have done a lot of work in standards, and it's all very good. It's an international body. One of the things that they've done that I particularly like is the High Fives project. And the High Fives project, it hasn't done its final report yet, although the interim report came out in 2013. What they did was produce a standardization, a standard procedure for the NHS, and not for the NHS, for healthcare. And this standard procedure was trialed in several different hospitals or health settings across the world to see how it was received by the people under trying to follow the standard. And unfortunately, there isn't a final report yet, so I don't really know how that went down. I know that in some of the interim reports, there's been a bit of criticism for people not wanting to actually follow a standard. They'd rather just do it their own way. And doing it their own way means that not everybody understands what's going on, and there is a lot of variation in output. So these are some of the control measures that are there in healthcare that are trying to prevent error in the NHS, in healthcare. Are these control measures working? Well, I'm looking at a few more websites here where I'm going to cover walkarounds, the workarounds. I don't know if you know what a workaround is, but I'll come on to that in a minute. The Care Quality Commission, clinical audits, quality accounts. Quality accounts have to be published in the NHS annually from each trust to say how they've performed in terms of quality. But quality in the NHS isn't quality of work, it's quality of output, and it's all based on output measures. Whistleblowing and a just culture. I've started off with the accident triangle, and not everybody agrees with the accident triangle, but it's used mainly in health and safety. But what it says that for one major accident, you've got to have a whole range of unsafe accidents or near misses below that. And the way to prevent that one death at the top is to reduce the number of errors at the bottom. And when I've done my health and safety training, when I was working in manufacturing, we believed in that, and our main aim was to reduce all of the errors, the minor errors, and hopefully that would prevent the major errors happening. And it seemed to be pretty successful to me. Workarounds. So the point I was making there is, if we have got so many problems in the NHS, is it because we're not addressing the minor errors? Workarounds. I don't know if you've heard of a workaround, but it's a very common saying in the NHS, and that is when they've got a procedure that's difficult to follow, they create a workaround, and it's sort of an unofficial official workaround. I'm sure it happens in other industries as well, but I've only ever heard it as something that's talked of and discussed, saying, "Oh, we've got a workaround for that." And there's quite a lot of literature on the web that condemns this practice of creating workarounds. You know, if a procedure is difficult to follow or makes the problem worse, why don't you change the procedure instead of having an unofficial workaround? Because of the nature of this webinar, I'm being a little bit critical, because that's the only way I can put the point over. In fact, I've had a lot of treatments in the NHS and have never had a single problem myself. The NHS do a fantastic job. It's just that there is this problem that there are too many errors. CQC inspections, the number of hospitals in special measures. I haven't got a chance to go into all of the ramifications of special measures, but you can see there that just at the moment there are a number of hospitals in special measures. That means they've had an inspection that they have basically failed. Inspection reports. Here's a typical inspection report, and you can see that they're only good in one area, and that's whether there is a caring atmosphere to their patients. All the other areas require improvement, and that's absolutely not untypical. Clinical audit is a big thing in the NHS, and there's loads of literature on it, but I've had a lot of trouble finding specific clinical audit reports. Now, to me, both in clinical audit and inspections, what I would like to do as an ex-quality manager and a CQ and an auditor, I'd have a look at what the policy was and to see if that policy was, what the procedures were, and to see if those procedures were being implemented. Well, the NHS have got these standard operating procedures, which they have to have for all of their activities. But in all of the reports that I've read, I don't see any mention of quality of these standard operating procedures. Yet we know for a fact that the standard operating procedures are full of workarounds. So I really don't see how you can have an audit without making reference to the procedures that people are supposed to be working to. Quality accounts. Every trust has to produce a set of quality accounts every year, and right at the back of these quality accounts there are a load of national audit recommendations, areas for improvement, and then it goes on to somewhere, it goes on to targets that they have for the coming year. And the targets are often things like reducing the length of time that patients have to wait, the number of patients that don't complain, all those sorts of issues, which are all output measures rather than what's going on at the time. Whistleblowing, that's a big issue in the NHS, and there'll be a lot about that on this programme tonight on Panorama. They'll mention whistleblowing all the time because people in the NHS are afraid to say what's gone wrong because they'll get blamed. And if this wasn't an issue, there wouldn't be so much information about it on the internet, or even on this, which is the NHS England website, talking about, yeah, you're allowed to whistleblow, you won't be punished if you blow a whistle, but that's not the case. There's also a lot of work going on. Again, this is NHS England, to try and introduce a just culture in the NHS. And a just culture means that you shouldn't be victimised if you complain about something. And if people weren't being victimised, then you wouldn't need this just culture. So it's clear that people are afraid to open their mouths in the NHS when there's an issue that they think is a problem. So we looked at an issue, then we looked at control measures, and now we've just looked at whether those control measures are working. Obviously, we can only have a very quick look, and to really get to the nitty-gritty of this, you need to do some of these searches yourselves and read through some of the documents. So, what's this telling us? A lot of those control measures are trying to control output, but not work in practice. So is it that the issue is centered around what we do and how we do it, rather than what our final output is? And is the issue really being addressed by those current measures? I haven't covered all of the measures. There are others, but they're all of the same ilk. Measuring output and trying to improve output. The NHS isn't sitting back and doing nothing. They have got some improvement initiatives, and there are quite a few of them. The main one being what they call quality improvement. They've got the model hospital. They've got get it right first time reports. They've got a complete organisation called NHS Improvements, and they've got the quality output framework and Quinn that try and suggest to trusts where they should be improving, and some of those improvements are financed through this CQI effort. So quality improvement, there's absolutely loads and loads and loads of detail on quality improvement within the NHS. This document's available and can let anybody can read it. They use Plan Do Study Act rather than Plan Do Check Act. I don't know why they do that, but I think it's something to do with the American influence. When the rest of us use Plan Do Check Act, there is a subtle difference in the two, but you'll have to do some investigation to find out about that. One of the problems with quality improvement, they make too big a deal of it. With continuous improvement, you just do a little bit of an improvement and get on with it. But with the quality improvement, they want to see a panel of people and reports written and all sorts of things. Most of these improvements are not necessarily in treatment, but it's in the application of treatment. Any treatment improvements would be done through NICE. I hope I'm making sense. Here's some examples of what these quality improvements projects look like, and you'll see that most of them are to do with improving outputs. We can't go and look at any individual one, but that document's available for you to have a look at on the internet. The model hospital, a great device. What it does is takes output measures from healthcare settings across the UK and charts them so that you can have a look under certain headings which hospitals in the UK are doing better than others. So it just rates you as to whether you're average or best or worst in terms of output measures. Unfortunately, it doesn't give you any help in how to go from being the worst to the best. And all of the measures are just output measures, and people and NHS settings have to report in every month or so what their output readings are. I don't know how much time they spend collecting all that data. Model hospital. Get it right first time. I think these reports are great. There's a whole series of them. If I can find it. Reports. There's a whole series of them, and they go through. They've done some study, and they've looked at a particular aspect of healthcare, and they've decided that these are get it right first time. If you follow the instructions in this document, you'll improve your service. I think it's really good, but there's no way of checking whether anyone's implemented what's been said in the report. So it's really just a bit of guidance that you can either take some notice of or not. And I don't, having looked at some of the inspection reports and quality accounts, I haven't seen any reference to these reports, the finding of these reports being applied. I'll have to speed up a little bit. I'm probably talking too much. NHS Improvements. This is an organisation set up to. I haven't got the link for that. You'll have to find it yourself, or I'll correct it for the when this presentations made available. NHS Improvements is just an organisation that's been set up to help improve organisations that are not performing, and the model hospital plays quite an important part of that, because they can identify hospitals that aren't performing very well. CQI is a set of areas where someone has decided, well, I won't go into this because you have to dig down too far. It's a set of areas where if an improvement's made, you will be the trust will be funded. Again, the quality outcome framework is a big guide as to, there's 116 pages. It's the different areas where you can improve what you're doing. The NHS long-term plan. It's a massive document, and it's how the NHS is going to improve over the next 10 years. I'll come back to that in more detail a bit later on, but it's there, and it's definitely an improvement that the NHS is using, an improvement initiative. I quite like the long-term plan. Okay, that's the improvement initiatives that are going on. Let's have a little look at quality management. There isn't any quality management in the NHS apart from in radiography and pathology in the laboratories and healthcare equipment manufacturers. They're all quite good. They are mainly registered to ISO 9001 or 2. So we all know what Duran has to say with his trilogy, quality planning, quality control, quality improvement. The NHS used to talk a little bit about quality control, and quality assurance, but now that they've gone on to QI, quality improvement, just on its own, they don't talk about quality management or quality control or quality assurance anymore. It's such a difficult subject, is quality in the NHS, and they've got all sorts of board papers and things that tell you about quality management, quality improvement in the NHS, and this is just page 3 of 14, and these are all the areas that are covered. And National Quality Board, quality surveillance, safeguarding, national clinical audit, CQC reports, MP's letters. It goes on and on and on. There is a multitude of different aspects, and this is just one document I'm showing you that's current now, that's got all these lists. I'm going to show you a few more just to show you how difficult quality management must be in the NHS. The definition of quality. This has come, I think, from America, where they've got 6 domains of quality, healthcare quality: safe, effective, patient-centered, timely, efficient, and equitable. Now, I don't disagree with any of that. It's how you implement those domains, how you meet those domains that's important. And I've only just come across this KLOE, and it's key. What is it? Key lines of inquiry. And this takes those 6 domains and tells you how to comply with them. And I was talking about these lists, and this goes on and on and on. And how you're supposed to translate all of this into quality management, I don't know. But it comes back to each of those 6 domains, to the levels that you get set from a CQC inspection. Outstanding, good, requires improvement, or inadequate. It's an interesting document. I've only just come across it, but I think it's been around for quite a while. I mentioned the long-term plan before. Here it is in a little bit more detail. And there's 136 pages in this. Oh, I've gone off from my notes a little bit, I'm afraid. What I wanted to say on these quality accounts was not quality accounts. Just a sec. I want to get the. Yeah, there's 136 pages to this long-term plan, and there's 190 references at the end. 190 references, here they are, to different papers that have been produced. But in all of those 136 pages and 190 references, there is no mention of quality management. Clearly, I haven't looked at all of those references in detail. There's 190 of them, but I've certainly gone through 136 pages in detail, and I've gone through some of the references, and I've read all of the titles of the references. There is no mention of quality management. So that's all I'll say about that. It's worth looking at the long-term plan. I do like it. I'll come back to it again in a minute. NHS Scotland used to be really good at quality management, but they seem to have changed now just to quality improvement. I can't find very much more on quality management anymore. They've just got quality improvement. You'll have to have a look at quality improvement in more detail and make your mind up. It's not what they say about it, it's what they're actually doing that's important, because it's not quality management. National guidance on system. This is new. It's just come out for the new joint healthcare system that's come out. And I just wanted to bring up, it came out in January 22. I just wanted to go to the end where they've got relevant quality data and intelligence. And this is internal quantitative and qualitative detail, and this is external. And you know, it's bad enough trying to follow ISO 9000, but if you're trying to follow all of these different elements of what's called quality management, or no, not quality management, but quality, then it really is difficult. Service design. It all stems from service design. If you Google service design, it's very difficult to find anything except this new document. And the document is from NHS Digital, which hasn't been around all that long, but they seem to be the people that are taking over service design. I can understand their problem trying to digitize the NHS when there's so much variation and there are no standard procedures. One thing about digitizing or making a computer model of anything, you've got to have a pretty stable starting point. We all remember the last big NHS computer system that failed. I don't know too much about that. It was quite a while ago, but it cost millions of pounds. So if the services aren't designed in the first place, they just seem to have evolved. They're on a pretty sticky wicket right from the beginning. Okay, so I've gone through some elements of quality management, but what I wanted to look at was sort of reframing the issue. And I started by saying there are too many errors and violations in the NHS. And I said that if you Googled that phrase, you got, was it 4.9 or 9.4 million hits in 30 seconds or something. Well, why not say, what can we do to minimise the number of errors and violations in the NHS? What can we do as quality professionals? And if you Google this phrase word for word in a search, I just did it, and I got 31 million hits in 0.63 seconds. So you can see that there is plenty of interest in people trying to do something about minimizing the number of errors and violations in the NHS. Okay, I think I'm running a bit short of time here. So we go on now to questions and answers. There's just a couple of things that I've added on to the bottom here. One's a little video clip on YouTube that talks about how the NHS works, and there's a similar one which is just called an alternative view. And I think these are probably produced by the Health Foundation. I haven't really got time to show them, but I will just to show you that I'm not doing nothing about this. I'm trying to make some inroads into the NHS, following a sort of quality management type structure, and I'm working on a project in Scarborough with their well, I'm not working on it, I'm planning a project on their A&E department to try and make some improvements there. And there is an opportunity at the bottom, if you want to go onto this site and read it, to put some comments in about what you think of this project. It would help me, and it would be nice to hear a comment on some quality professionals. So that's just another element to this talk. Okay, I think now that we need to start addressing some of the questions and answers, if there are any. So I'll stop talking now.
Thanks very much, Tom. That was very interesting, and we have had a lot of comments and questions come in. We only have just over 10 minutes. So I'll try and get through as many as possible, but any that we don't get through, Tom, maybe perhaps we can address offline and send out with the slides.
Yeah, my email's there, so people can just email me if they want.
Perfect, thank you. So I'm just going to start off with a couple of comments. I'll try to group some of the questions together. So Victoria said, I think that what you're demonstrating is the volume of paperwork, checklists, etc., is now non-manageable for those on the front line. Systems and processes are inefficient, time-consuming, non-cost effective, and staff are constantly pulled to other tasks, e.g., for example, occupational health teams pulled to doing COVID swab testing. So just kind of reiterating the point that you're making.
I agree with that entirely, and I feel absolutely sorry for people that work in the NHS. Although they do a fantastic job, and I've got no complaints from what's happened to me, I know how they're suffering, and it's just absolutely not their fault.
And another interesting question come in, looking at customer service, kind of asking the question, who is the customer of the NHS?
Can I comment on that as well? There are two aspects to service design. One is the medical aspects, getting all of the equipment and the treatments and the diagnosis is right. And the other one is the customer service, treating their customers, not how they treat them medically, but how they treat them face to face, welfare wise, and with courtesy. So services haven't been designed using these two different aspects of a service, but I'm doing quite a lot of work on that as well, because if as I said earlier, if the services aren't designed properly, then they're never going to have an effective quality management system. So we're trying to address the two aspects of service design which haven't been addressed before.
Thanks, Tom. And then there are a couple of questions that I'm going to lump together. A couple of people brought up the point of how do you overcome the NHS policy of not getting rid of people who are not up to the job? Perhaps they're redeployed into another role or department instead. And a similar question, someone saying, is there really any accountability? For example, when a bank or pharma company gets sued, they can typically take it. If a hospital trust constantly had penalties, I'm not sure that would happen. So just kind of looking at that accountability and if that has an effect on it.
Well, if you Google errors in the NHS or some of those tribunal services in the NHS, you'll see that there are a lot of doctors and nurses and other members of the health profession that do get victimized and do get their careers taken away from them, but for causing errors that really weren't there. The errors were almost unavoidable, and a lot of the errors that they get blamed for are at the end of the line. Most of those errors started right from the word go, when the patient first went to his doctor, and the information was misrecorded, information gets lost, people don't know how to fill in forms, and it ends up the person at the end of the line gets all of the blame for it and is punished. But it's all of the smaller misdemeanors where there's no corrective action taken to prevent that error happening again in the future. So I think that there is a degree of blame, but often it's misplaced. I talk too much, don't I? I'll try and stop talking so much.
No, it's obviously sparked a lot of debate and conversation. So just kind of touching on that as well, someone's brought up, and you mentioned it when you were talking about the culture of the NHS, with respect to distractions and doctors being interrupted in theatres. Was there any comment on staff being empowered to speak out when they think that something is wrong?
Well, the Just Culture is supposed to do that, but if you listen to the Panorama programme tonight, you'll find that it just doesn't work. And one of the big reasons why people have to ask so many questions is nothing's ever put back in the right place because there isn't a right place, and also there's a reluctance to completely fill in forms, and it's usually the more senior people that don't fill in the forms. So someone further down the line gets some information and it's not complete, so they've got to go and ask a question. Without having a specific procedure to work to, how can you say that someone's done something wrong when they haven't been told exactly what they should be doing in the first place?
Thank you. And then the next couple of questions, not directly related to something that was mentioned in the presentation, but just interesting and something that you may have come across. So someone has asked, since the NHS has to work with other agencies, councils, etc., would the collaborative working standard, ISO 44001, make any difference if anyone in the NHS has time to read it? I don't know if you're familiar with that standard.
Within the NHS, doctors and nurses work to separate agencies, and they have a great deal of difficulty communicating between doctors and nurses in the same hospital. So when you come to outside agencies, it's going to be a lot more difficult. But I think there is a lot more work going on that aspect with some of the digital platforms that are now available. There's going to be a lot more inter-agency working. And I know that in my area, I'm a member of a couple of groups, and there is a lot of work going on to try and improve that. But I did show you that document on the new quality structure for these integrated health sectors, units, and it's going to be really difficult because they're starting from such a low base. So I think it's going to be difficult, but there are people working on it.
Okay, hopefully that answers your question, Peter. And the other one someone asked, are quality management systems in healthcare linked to ESG processes? So I presume the sustainability processes, environment, sustainability and governance, is that a consideration in any of these systems?
There is a lot of work going on in sustainability, but it's sort of done independently. It's a bit funny, and most of it is sort of putting trees in the garden and things. That there are some projects, and some of the QI projects are to reduce the use of plastics and single-use items in the NHS. But if it's not funded, they don't do it. And there isn't a lot of funding in that area. There are a lot of people that are concerned about it, but I don't think there's as much work going on as there should be. I was listening to a program on, there's been a series of webinars on future hospital design, and someone's been doing some research into the number of the amount of waste that comes out of an operating theatre for the same operation across different healthcare settings. And the difference is absolutely phenomenal. You know, some of them can have a couple of bags of waste after an operation, and some of them can have a skipful for exactly the same work. So there are still a lot of areas that can be looked at, and I don't think it is very well organised centrally. It's up to individuals.
Yeah, and that seems to be the problem when there's so many different aspects to it.
Sorry. What I was going to say is that the individual health settings aren't their own bosses. There's so much regulation above them that's dictating what they do. They haven't got time to do their own thing. They're trying so hard to meet all of the requirements that everybody else is set upon them.
I'm just gonna, there's one last question. There's a few comments in the chat, but there's one last question in the chat, and then I noticed that someone's got their hand up, so I'll just do those 2 questions just before we finish up. So the final question was, if anything is going to change, who will start the change?
Me. I'm trying my hardest. I'm absolutely trying my hardest. I've no idea. In 5 years, I haven't really found anyone that really supports what I say needs to be done. Now there are all sorts of different types of quality management systems, but QI might work or it might not. As far as I can see, it's not going to work. So they've got to change what they're doing, but they put all their eggs into QI. So I really don't know what we can do. I've been thinking of contacting the government. Maybe the CQI can do something.
And it seems you've got people joining you here. Paul and Victoria in the chat they've posted and agree absolutely what you're saying. So please get in touch with Tom and look to getting involved in the health SIG as well if you would like to join us. Just before we finish up, John, you have very patiently had your hand up. So this is going to be the final question of the session.
Oh, okay, thanks. Thank you, Tom. Sorry, I lost the chat bit, which is why I put my hand up. Just a point, I think you only mentioned the board of the hospital once in some information that they were being overwhelmed with. To my mind, it's actually the board who are responsible for establishing the right culture for quality in the organisation. And of course, they're the people who have the accountability to make sure that the controls are working. So I think probably there is a bit more independence than you suggest at board level, in spite of the centralisation in the health system. And the other quick point is certainly where I am in Wales, there's quite a lot going on in terms of the circular economy for organisations in the public sector to recycle what they do. And quite a lot of development in the rest of the UK in terms of anchor organisations making much more use of their local communities for goods and services and sort of rethinking the whole joined up work. But I think the board is an important element of making sure we get the quality that we need.
Yeah, I don't disagree with you at all there. But how do you get in touch with them? How do you influence them?
Well, they're all identified on their websites, and actually I tend to find both for doctors and the public that the non-execs are actually reasonably accessible. It's worth contacting them and saying, are you asking the right questions?
Yeah, I have. Yeah, I've thought about it, but I haven't had any response from the inroads that I've made. Even in my own hospital, University Hospital Birmingham, I'm having trouble talking to the right people, and I'm lecturing to the students. So I agree with what you say. They have got the responsibility, but whether they'll take any notice of someone like me trying to butt in, I don't know. I'll try a bit harder.
Do. Thanks, Tom.
Thanks.
Paul has just made a comment saying he successfully lobbied the government with a change in policy, and I think there's some comments previous to that. So perhaps Paul should get in touch with Tom and continue that conversation. We have just gone over 1:30, so I'm going to close the webinar there. Thank you so much to everyone for coming along and for all of your questions and comments. It's really great to see people getting involved. And thank you very much to Dr. Tom Rose for presenting all of this to us and sparking such great debate. We look forward to future presentations and looking for the work to continue. So thank you very much and look forward to seeing you all at future webinars.
Thank you, Caroline.